Thank you. Good morning. It is a pleasure to join this society. I've been able to do this before, and it's always nice to see old friends and make new ones. Now, I am supposed to discuss what I would say a conceptual talk on knee morphotyping. And the more you see patients, the more you see different knees. Sometimes you're struck that one knee is not really like the other. And it involves the way you take care of these patients, and it involves the development of arthritis, as we've been seeing earlier this morning. And we are tough in surgery, but we really need sometimes to think about basic science as well, and this talk goes into that subject. The osteoarthritis, we've heard this time and again, obviously is a biomechanical disease, and genetics has to do with it. We don't really know how much, but it has to do with it, and of course load and gravity is essential, because in this load, you may be injured, you may be overweight, you depend on the activity level that you perform with your knees. Alignment, obviously, we know that very well, how important that is. But then comes this new element like about morphotype. One knee is not like the other one. If you look at this MRI, you don't see really anything very special of this MRI, but if you look at the left X-ray, you would agree with me that this medial condyle is relatively small, and in this particular case, the intercondylar notch is particularly wide. If you look at this illustration, you can understand that this medial femoral condyle really will have quite a bit of load to carry, and obviously then will be subject to more degeneration, or degeneration that at least goes faster than in what we would call normal situation. You agree with me, there's nothing very much special to see on this isolated MRI, though the medial femoral condyle may be a little bit narrow, and the lateral femoral condyle then again will be a little bit wider. Would you agree? And another ortho-CT we take from a series of patients that we see, smaller medial femoral condyle and larger lateral femoral condyle. By the way, you see some degeneration of the cartilage in this medial femoral condyle. Now, you may have morphotypes, and this is a little bit what I want to discuss about, that present with small medial condyles. And you have people with larger medial condyles, and then again people with having a wide notch. And this is taken from patients that you see in your daily practice. Now we will focus a little bit on these small medial condyles. Do they really exist? And if so, do they differ, or are they in danger for faster or quicker cartilage degeneration than what we would call a normal knee joint, normal knee condyle? So these smaller medial condyles, you can understand that the contact pressure is increasing, and this may be a risk factor for further degeneration. But if it is degeneration in the medial femoral condyle of a smaller medial condyle, then you would agree that the meniscus will have more load to bear and may be degenerated, and then leads to meniscectomy, and then leads to faster osteoarthritis, if you follow my thoughts. And of course, these particular patients may be a little bit more BMI, or may have impact activities that are harder than normal situations. So it increases contact pressure and leads to early degeneration potentially. Would this be true? So we designed, the group in Antwerp designed this pilot study controlling these 20 small medial condyle femurs, which they assembled in the series, versus what they would then rather call control subjects, normally joints as we would see, and whether of these would one more than the other present more degeneration. And then they rescaled this to exclude the side differences and looked at morphological measurements and then a finite element analysis, biomechanical analysis that followed from the first findings. And then they looked at these morphological measurements and the methodologies. As you see, they took several points, as we would do in navigation, on the tibial plateau, on the femoral condyle. This was how everything was measured, AP and also medial lateral, and we'll see what it leads. So, what did they find in these morphological measurements regarding the medial condyle width? In fact, it was clear that small medial condyles are really smaller than the control groups. That was one point. And the distance between the average control is illustrated in color here. Now, when we look at medial-lateral findings, the baseline, you see here, the baseline is the control group, and you agree with me that in this comparison, the medial femoral condyle in a small medial condyle group is really much smaller. The lateral condyle, then again, is a little bit larger. The notch width is like in between, and the medial lateral distance does not really differ from the control group. If you look at the AP, and that is quite remarkable, you see again the group, the control group with the mean illustrated in this line, and then you see all these measurements are smaller. The lateral AP, the medial AP, the posterior offset, lateral and medial. So these findings, there is really a difference between the medial, small medial femoral condyle morphotype versus what we would call the normal group. And this pilot study further went on to the finite element analysis, whether with these findings of smaller condyles being smaller with more impact on the tibial plateau, would that lead to a derangement or further degeneration in the cartilage. And here is the estimation, of course, it's finite element analysis of the contact pressure. And again, you can see that the control group has less contact pressure because of the more surface for weight bearing versus the small medial condyle. It's not really remarkable, it's not dramatic, but it is still there. But then again, when we study this further down, the road with final element analysis, when you have an intact meniscus, the difference is relatively okay. But if you do meniscectomy because of overload, then you see that the pressure is really remarkable. And the conclusion of this, obviously, is there is a large spectrum of morphotypes. They are linked somehow to early pathology if we consider the final element analysis, and the morphotype and inferior outcome after early arthroplasty, because that's the point where we want to lead our investigation. If you put a total knee arthroplasty on these joints, you see that in the small medial femoral condyle type, these implants will be too large. And if you see this more clearly here, close up, you will have, and you know that from the clinics, it happens that you have soft tissue impingement on the medial femoral condyle on the edge of the prosthesis, and possibly also you may have PCL impingement in case of cruciate retaining implants. So that's an issue, and maybe a reason why some of these total knee arthroplasties do not function really well. On the other hand, if you use a unicompartmental replacement, which obviously might be a very good solution, then the size is different. you may have soft tissue impingement in these cases, and then you will agree with me, you'll take a smaller size. But if you take a smaller size, you increase the pressure on this particular implant, and maybe this may be an element for loosening. You never know. So we need to think about this and look at knee at risk identification, because we may think it is linked to early failure of the native knee if you're confronted with that. It's looking also at an early failure rate if you move on to arthroplasty, because there is no other alternative. So we probably, it would be optimal if we would have more arthroplasty shapes available, and be careful when we look and address issues with these abnormal morphotypes. So thank you very much for your attention, and if you're interested, join us next year in the meniscus meeting.
Many thanks, Dr. Verdonk. Professor Verdonk is a well-known and famous doctor in the field of arthroscopy. As you know, he was the past president of the ESCA, and the past president, or the first past president of CIA, Gascot. What is the abbreviation of Gascot?
I was attending Gascot meetings, Gascot meetings. Thank you. Yes, indeed.
Yes. I don't know the abbreviation of this. The Gascot.
Say again?
It is written here. The abbreviation.
Gascot is the Italian society.
Head of Orthopedic and Trauma Department, La Tassana Civil Hospital, Belgium. Professor, the knee after meniscectomy will certainly ended up in osteoarthritis, correct?
Yes, that is what we fear.
After how long, and what are the different factors leading to this?
It's a little bit, as I mentioned here in my presentation.
Yes.
It's overload.
Overload.
Overload, BMI, activity.
Yes.
That increase the chances. But the first and foremost important element regarding this osteoarthritis and meniscectomy is alignment. We have to look at alignment as a first pathology and correct it accordingly. And then the second element that comes into play is stability. And we know, because of huge sports activities in youth, both female and males, football, this really injures the ACL and then brings the stability of the knee in danger, then overloads the meniscus, and this leads to osteoarthritis. And we try to stabilize the knee joints. We kind of quite securely can do that. But we also have to think about the presence of the lesions of menisci at that very moment. And the ACL protects the meniscus, but the meniscus protects the ACL. And very often, when we discuss ACL repair, we only look at the technique of the ACL repair, but we should also please mention what the status is of the meniscus at this very moment. And if we do not mention that, then we only discuss techniques of ACL, which may be different, both very effective, but if the meniscus has been removed, results will be worse in one than in the other group. So that's the importance of the meniscus, I would suggest.
Thank you. The floor is open now for discussion. Any question? Dr. Izzat?
The microphone here, please. Yeah, I hear you.
Sometimes we are confronted with a patient with multiple MRI she came when he comes to my clinic or whatever clinic, and he have a bucket handle tear from root to root, and it is neglected for 1 year or so. Do you think that we can suture that meniscus, or we remove it, or leave it as a load sharing inside, if he has a good range of motion?
Thank you for this question. Is some things that we really see, it's rare, but it happens that you see these. And the experience I have with these particular cases of a chronic bucket handle tear, if you have this in a very young patient, then you lose elasticity and you will not be able to reduce it. If the patient, that is my experience, if the patient gets older, it may be possible to reduce it, because at the moment of the tear, the meniscus is not contracting anymore, it's not contracting. And you should really try to replace it. That would be the first thing to do. But sometimes you're unlucky. And from then on, if this is an isolated cases, and the knee is stable and the alignment is good, survival of this knee joint may be possible. But the very moment there is some slight alignment deformity or a little bit of instability, this knee will go down the drain. But we should save the meniscus and take the risk of failure, because we know that when you suture a meniscus, it's most effective. You have like 75–85% chances. And Philippe Beaufils and Nicolas Pujol from Versailles in France have investigated results of meniscus suture that you had to redo a new arthroscopy because there were complaints. And they investigated and found that when you do a redo arthroscopy to check for a failed suture, and you have to resect the meniscus, at that moment you resect less than you would have done in the first place. So the slogan from the ESCA group is, take the risk of failure. Not that you should suture all degenerative tears, that's not what I mean, but the traumatic tears, you should take the risk of failure and tell your patients you have 75% of good chances, and if it fails, well, in your mind, you know you will resect less than you would have done in the first place.
So, for horizontal tear, you teach us if it is from periphery to inside. You open and suture it. You still do that, or you do it arthroscopic now?
We would do that arthroscopically, but the cases you mention are cases in the young individuals where there is no surface tear. If you look at the meniscus on arthroscopy, you see no tear. But still they have pain, they're young, they're active, and you have an MRI where there is this horizontal tear coming from outside inside. And I guess in these instances, this open surgery is most effective. But of course, if you've been trained to do arthroscopy, you do not really know how to approach these posterior corner. And that was the advantage when I was young. I had to remove all the meniscus for my boss. He said, if you have a meniscus that is torn, remove it all. So we did very often a posterior incision to resect this posterior horn, thinking we would do good. But this is an incision that you can really use very well and take care of these young, horizontal, non-perforating tears that are painful. Just past 50. Just past 50. But now there are alternatives. There are alternatives. You have to balance the morbidity of a meniscal transplantation, because if you do that, these patients are out of work like for 6 months before they can go back. And you have to balance that towards their complaints. and the chronicity of their complaints. So I think I would lower down the age of transplantation because there are alternatives with, I would say, the new surface. It's a product that is not really on the market yet, but it's polyurethane you can put in between medial femoral condyle and medial tibial plateau. And that replaces the meniscus, and that doesn't go through all the morbidity of a meniscal transplant. But I would say 40 to 50 years of age, usually.
Any more questions?
Yes, please.
Dr. Mohib.
That is a very good question. It's a little bit like the media. These posterior root tears, everybody has seen that before. We didn't really very much care about that unless it occurred in younger people. In younger people, I would say, is 30, 35, maybe 40. But most of the root tears that I see is part of patients that are 50, 60, 65, where the tissue is degenerated, where you can classify them, but it's degenerated. You cannot just suture it. It's like a rotten rotator cuff. You can try to put it together, but it will never heal. So I think when you're confronted with these patients where the knee on X-ray is perfect, the MRI shows you this root tear, that you have to explain to these patients that is probably the beginning of the end. And suturing it is a little bit complicated in these instances. And then the grasp in this tissue that is degenerated and led to the tear is not good for healing. So I'm a little bit disappointed that we put the root tears back again on the agenda without looking at the age of the patient. Because it's disappointing. And in these cases, as I mentioned to you, take the risk of failure. I wouldn't take the risk of failure in these cases.
Not in this case.
Not in this.
Anterior horn tear.
Exactly. Yes.
Thank you. Now we have to close. It is a time of lunch. Thank you, Professor Verdonk. Thank you all.
Just before we